everyone. I'm Kanitha from National Health Commission's Office of Thailand. Thank you for all of you to participating our webinar on health in all policy in the times of COVID-19. What role for the health sector moving forward? I hope you will enjoy our webinar. And I have some announcement. The first one, the speaker will present one by one. After all speaker present, there will be an open for the discussion. And please mute your microphone while listening the presentation. If you have if you have any question, please take in the chat box. And we will record this webinar and take a photo of the webinar and share it on the Global Network for Health Our Policy website later. And lastly, at the end of the webinar, I will send you a questionnaire link in the chat box and to your email. And before the webinar start, I would like to invite all of you to take a group photo together. Please turn on your camera. Please, I will count 1, 2, 3, and turn on your camera, please. Please wait for a while. Thank you. Thank you. Please turn on your camera, please. Okay. Okay. I นับเลยนะ I will count 1, 2, 3 and then smile 1, 2, 3 smile. Okay. Okay, one more 1, 2, 3 smile. Okay, thank you very much. Thank you very much. And next, I will give a microphone to Dr. Weerasak Putthasri, Deputy Secretary General of NHCO Thailand, to give an opening remark.
Okay. Good afternoon, good morning, and good morning, speaker and participants. Welcome to the webinar. You may be informed that the webinar is the fourth in the series of the webinar on the multi-sectoral collaborations in response to the COVID-19. The COVID-19 has impacted almost all dimensions of the society that we can demonstrate and highlight how multi-sectoral collaboration approach is implemented in the time of such crisis. In the webinar in April and June, we discussed on the civil society participation on the COVID-19. We got many experience from the speakers, especially for the synergy of action of active citizens to help the countries fighting against COVID-19, so-called multi-sectoral collaborations. The webinar in August to share the experience and discuss on the role of the youth and students in Asian countries to support community to fight the COVID-19 as well. In September, we organized the webinar on the role of the government sectors and multi-sectoral collaborations. We saw that and many active of the government sectors and the social interventions are officially advised, such as the regular of washing hands, using alcohol gel, wearing the medical mask. And the prompt response and high-level commission of the government is very crucial for an effective COVID controls. If you see the slide, since the COVID-19 come this year early, we've seen it itself and also the social intervention that we implement affect not only on health and health service only, but we found that it's the challenges of the food security, the issue of the infodemic and fake news. The people lost their job and many aspects of the quality of life challenges. That's why today we are looking forward to learn how is the main role of the health sector to other sector as well. This will be a good evidence according to the keyword and concept of the health in on policy or HiAP. We need intersectoral action for COVID policy, taking account of the health concern across sector in decision-making process and implementations. This collegial partnership is the combination of good governance in design, delivery, and benefit together. May I remind you to the SDGs, high-level global commitment. The SDG target and goals are interrelated and need multi-sectoral collaboration. We probably use these pictures as the framework of to discuss today why and how health sector to move the social forward the pandemic circumstance and its consequences. Finally, we aim to have the synthesis report that we learn from multi-sectoral action from the experience, how we can do synergistic among working among these sectors. We plan to organize the webinar again in December with that report and practical recommendation that we hope. It is much important document and evidence for further support of the health in all policy framework and implementations. In globally, health system and normal lives of the humanity are almost disrupted from the COVID-19 pandemic. But the other side of the coin, it gave us opportunity to prove the health in our policy concept and multi-sectoral collaboration is realistic and workable. Thank you.
Thank you. Thank you very much. That was a lovely opening. I'm now going to turn, after Weerasak has given us an introduction to the rationale for these webinars, to welcome our other speakers. Firstly, I'm going to list them, and then I'm going to hand over to Sharon Friel, who will be launching us off. Firstly, thank you and welcome to Sharon Friel, who's a Professor of Health Equity and Director of the Menzies Centre for Health Governance at the School of Regulation and Global Governance, RegNet, at the Australian National University. I would just like to mention that Sharon Friel was also head of the Secretariat in London when WHO ran the Global Commission on the Social Determinants of Health. I'd then also like to welcome Dr. Anna Stevenson from the Canterbury District Health Board from New Zealand. Anna is a public health physician from the Canterbury District. She's been part of our Health in All Policies networks for many years now and has done some fantastic work on the ground in Health in All Policies. And she's a real inspiration to learn from. And then finally, I'd like to welcome Dr. Warisa Panichkraengkrai from the International Health Policy Program at the Ministry of Public Health from Thailand. Warisa is a researcher from the International Health Policy Program at the Ministry of Public Health in Thailand and also serves as in the scientific subcommittee for this year at the National Health Assembly. So welcome all of you, and we all look forward to hearing what you have to say. And then after we've heard the speakers, we'll go into an open discussion, and we really welcome those in the audience today to submit any questions they wish via the chat. We already have 2 questions that we will address that were sent to us beforehand. Now I'm going to hand over to Dr. Sharon Friel. Over to you, Sharon. Thank you.
Lovely, thank you, Nicole. Let me just share my screen. Yeah, so thank you. So I wanted to share some of the work that we've done here in Australia in the, like every country around the world, grappling with the economic, the social and the health policy responses to COVID-19. And what we did was we looked at how the Australian government had responded across a whole load of different policy areas. And we shone a light in terms of health and health inequities in particular across those policy responses. many of them which were quite fantastic, and I'll speak about some of the missed opportunities. And of course, for us concerned about health and all policies, trying to understand not only how actions across sectors can affect health and health inequities, but how to enable that sort of action. So I just want to share some of that work that we've done here in the Australian context. I've put, that's the cover of the report that's on the screen, and the link to the report. If you're interested, I can always email that around afterwards. But before I speak about this, as is the case in many countries around the world, health inequities are getting worse. We thought things were going quite well within Australia. This is premature death, age standardised premature mortality for men and women. The red line at the top is the lowest income quintile, and the grey line at the bottom is the highest income quintile. And in pretty much every quintile, things were getting a bit better in terms of premature death. But something happened. Something happened around about 2010, 2011. And of concern is the stagnation, and in some, well, you can see for men, actually that rate going up again in the lowest income quintile, and the stagnation for the females in that income quintile as well as the next one. So there was something going wrong within society anyway, affecting health inequities within Australia. And Australia is, of course, experiencing the same sorts of health inequities as many other countries around the world. So we had something happening anyway that was reinforcing and exacerbating health inequities. And we know that what drives all of that is material resource, is control over our lives, and voice in the decision-making processes that affect our lives. And I've spoken about this in the context of dignity, in the context of preventing poor health, and also in the context of environmental degradation, environmental harms that we're certainly seeing throughout the world. So material resource, control, and a voice in the decision-making processes. And of course, that takes us into the health sector and well beyond the health sector. So along came COVID-19, and the Australian government, as happened in many other countries around the world, the Australian government acted, and actually we acted very quickly within Australia. And these are some of the responses that were put in place in that time period. So between March and June of this year. There's no particular reason why I've chosen those dates. It was just that those were the dates that we had access to some of the data. And all I really want to focus on is the column that's titled Fed, and that's the federal government. At the national level, we have the federated system in Australia. The other columns are to do with the states and territories. So you can see across these different areas of employment, of income, of cost of living, of childcare, housing, infrastructure, community, healthcare, there were a lot of things, a lot of policy measures put in place. Apart from healthcare, none of them were done from a health perspective. None of them used a health lens at all. But my argument would be, who cares? Because some of them were really good for health, and I'll speak about just a few of them in a second. Of course, these policy responses were put in place to keep the economy afloat. That was what drove these policy responses. As COVID was devastating the economy, what was put in place? So let me just reflect, and there were 156 measures put in place, and I have to applaud some of them, not all of them. So I want to speak about three. I want to speak about income security, because material resource being so important from a health and a health equity perspective. Before COVID, in the Australian context, we had 14% of the population living in poverty. We've had growing income inequality, even although we're a rich country, and we've got one of the highest levels of precarious employment in the OECD. And by precarious employment, that includes things like 0-hour contracts. That means there's levels, very high levels of job insecurity. That means that there is very high levels of income insecurity. And it means that the wider social protections that come through employment are lacking. And we know the vast body of evidence tells us that that's really harmful for health and, of course, very socially distributed. That was before COVID. COVID hit, and these are two of the policy measures that were put in place. So JobKeeper, that was a wage subsidy that helped businesses keep employing their staff. So in terms of job security, that was very important. That was, I mean, really to applaud that. But it was also very socially graded, and for many people in casual employment, depending on how long they had been employed, they weren't really being supported by this. And so the argument could be that whilst this has kept companies going, which is good for the economy and certainly good for people who were employed in those companies, it has left some people behind. The second response that was really important, and this is a social protection policy, was the additional income to people on these income support schemes, on these social support schemes, an additional $550 Australian every 2 weeks. Again, that was about income security. It wasn't from a health perspective, but the analysis and some of the discussions that have been in place around this, people were reporting that they're now able to buy fresh fruit and vegetables. Something simple like that, let alone all of the other health benefits that comes from income security, just something like that. So there's a very strong health and social sector lobby trying to get this to remain. It's been pulled back, but a very strong argument for having financial income security. I mean, I would say if we send people back into the financial conditions that were killing them in the first place, that really has to create us to pause for thought as a society. So from a health and all policies perspective, being at that table in the deliberations around social support schemes and wage. The other really good thing that happened in response to COVID was in the childcare sector. So before COVID, we had 44% of Australian children who were from socially disadvantaged backgrounds were already struggling by the time they got into school. And we know that the early years, early child development, early childcare services can be incredibly important for social, emotional and cognitive development, which is really good for their societal well-being, their educational well-being and attainment, but also very good from a health protection perspective. So doing something about that should always have been on the cards from a health and all policies lens. And then COVID hit. And what the federal government introduced, it was called the Early Childhood Education and Care Relief Package. And this was also about keeping people in work, but keeping them in work within the early childhood services and care sector. So an economic policy. But what it did was it delivered childcare free to everybody. And that, of course, was phenomenal for, if you look at the figure at the top of the screen, for those children from socially disadvantaged households were now able to access this childcare environment. That's great for the child. It also has been good particularly for mothers as carers, being able to choose to go into the workforce, and that brings some more material security, material resource into the household. The Australian government did nothing in the other in primary or secondary schools, and we can speak about all of the problems that means from a health perspective. But I think the importance of that childcare package for health and health as a health policy in many respects. And then the third area that I just want to mention is housing. We know that shelter, we know that housing, the quality of housing, access to quality housing matters for our physical health, and it also matters for our mental health. And housing is one of those very, very socially graded areas. And in Australia before COVID, you can see what I've said on the screen, in terms of access to affordable either private or public housing has been woeful, has been just terrible within the country. And there's been very, very little policy attention to public housing. So all of the health and the inequality, the health inequality, social and health inequalities associated with that, there has been nothing. So I'm highlighting this as an absolute missed opportunity within the Australian context with COVID response. What the government introduced was, it was called the Home Builders Programme. This was simply a grant that was available for people to either renovate their homes or buy a new home. And it was the people who were eligible for it were those people who could already afford to do that. So the inequality was just exacerbated. I just show you this quote to do with housing that comes from the head of the state of Victoria within Australia, and really just speaking to some of the embedded inequalities within society that are absolutely illuminated through this issue of housing. And so just being able to deal with COVID acutely, a very inequitable situation, and of course, as I say, a missed opportunity. So going forward, I think there is a policy window of opportunity, because it will certainly down in the state of in Victoria. And so just finally, a reflection on what were some of the big missed opportunities. So there was nothing to address the structural drivers of social and health inequities within the country. And in some respects, you can say, well, that's not a surprise. You know, this was a very acute, a very immediate response to deal with COVID-19, and I absolutely applaud the government for that. But in thinking about, the housing, the employment situation, we could have had some attention to the underlying causes of that. There was absolute silence on climate change, and perhaps we'll speak about that in the panel and hopefully in questions from colleagues, because we know the connections between climate change and health and the alliances that could be built between those sectors. And we've seen incredible regulatory failure within the Australian context, which has just demonstrated some of our magnificent challenges for health and all policies within the country, and it also goes to the governance biases. So whilst we've had the COVID policy responses, some of the ones that I've just spoken about, there has also been a deregulation agenda put in place, actually weakening some of the protective, some of the environmental laws have been reduced. So things coming in that are going to be really quite devastating in the long term. And the governance bias. So we saw a very significant change take place within the Australian governance setup. And so that was being changed, it was being created, the National Committee was being created that was replacing what we call COAG within the Council of Australian Governments. And there was an opportunity right then to actually do something about all of the biases that people have been critical of, the lack of social or health voice at the table, the lack of diversity at the table, and it's not exclusively, but it's still dominated by old white men. There was an opportunity to change that, to bring some of the issues that us, if we're interested in health and all policies or environment and all policies, or just equity more broadly, there was a chance. But of course, it's actually become much more, well, not much more, but it's maintained the status quo, which I think is very concerning for us going forward. So I hope that's raised some issues that we can speak about within the chat and within the panel discussion. So over to you, Nicole. Thanks.
And thank you very much, Sharon. That was a beautiful presentation. And you've raised some very important issues related to sustaining health signal policies going into the future, and what is the role of the health sector in these different conversations that are happening on the economy. It's a difficult role for the health sector, I think, given it has to do both advising on the control of the epidemic, as well as now advising on the rebuilding of societies in a better way to avoid future epidemics. So it's a huge challenge. Now moving on, I'd like to ask Dr. Anna Stevenson if she would please share her screen with us.
You're on mute, Anna.
Thanks, Sharon. It's amazing how long it takes us to learn these things, isn't it? So I just wanted to introduce where I come from, which is Christchurch, New Zealand, and I work for the Canterbury District Health Board there. And you'll see that photo is one of the things that we did in our lockdown. We were asked to put teddy bears or other soft toys in our windows so that when families were out walking with their children, we could hunt the teddy bears down. And people really responded to that. So we just thought that was a nice little photo. Can I have the next slide, please? So this is to explain in more detail who I am and where I come from. I'm part of our local public health unit, which is responsible for things like water quality, air quality, emergency responses, many health promotion activities. And we, since 2011, have had a specific health and all policies team. And that was a team photo that we had taken a couple of years ago now, which people seem to like, so I put it up there. When I circulated this presentation to our leadership team, one of the points that they wanted me to make was that although we do have a specific team, in fact, our whole public health unit was restructured after the earthquakes. We had a catastrophic series of earthquakes here in Canterbury in 2010, 2011. And after those earthquakes, we restructured our public health unit so that everybody who works here has a health and all policies focus to their work. And that means that we think very hard in all of our work about determinants of health, about equity, about evidence bases, and also something peculiar to New Zealand, something called the Treaty of Waitangi, which was a treaty made between the English Crown and the Indigenous people of New Zealand, the Maori people, way back in 1840, and has perhaps been more honoured in the breach until relatively recently. But from our perspective, it's really important to work towards making that treaty a reality. Over the years, we've developed a lot of joint work plans with our local government and our regional government, particularly focusing around things like water quality, things like emergency management, things like smoke-free housing. And increasingly, we've been invited to be part of many intersectoral projects with those government entities and with community entities. We, as a team, lead on all the submissions that our District Health Board puts into other agencies. And so we ensure that in all of those submissions, there's a really strong equity focus. And if you go to that website, which is at the bottom of the slide there, you can access all of our various publications and evaluations, sign up for our newsletter. The publications that we really wanted to highlight were something called Health Promotion Sustainability Through Environmental Design, which became the Integrated Recovery Planning Guide that was put out after our earthquake sequences. And now, a few years later, we've developed something called the Integrated Planning Guide. We thought we'd moved away from recovery. We're now back into a bit more business as usual. And what we really like about those guides is that they are co-designed and co-written by a number of agencies, not just by us. They're written by the various council groups, the various regional council groups, by urban designers, urban planners, by people who've got particular focus areas on, say, water quality or fuel poverty. And so they're very much a collaborative project, and that helps us to get buy-in. So this slide is what was happening in New Zealand before COVID came along. And I wanted to tell you about the Minister of Health that we had at the beginning of COVID. He's no longer that Minister of Health. But before he was elected about 4 years ago, he was quoted saying that 80% of the determinants of health sit outside of the health sector. And that is why right up front in Labour's health policy, we say that we are going to have health and all policies. So, of course, we were quite impressed with that. And as it turns out, we're not sure if he really understood what health and all policies meant, or perhaps he had a slightly different version of it than we might have. But certainly he had the language, he had the understanding about the importance of determinants of health. And he was talking about how he saw his role at the cabinet table in government as asking his other colleagues, how is the policy under discussion producing a health outcome in terms of housing, in terms of children, in terms of any area that's going to have an impact on health. So that was a really good place to start from. Many of you will have heard about the first ever wellbeing budget that got global praise. And that was based on our New Zealand Treasury's Living Standards framework, which I put in the slide here. And you can see that that framework is not just about money, it's about 4 different capitals that they have labelled here: social capital, natural capital, and financial and physical capital as well. And then I've mentioned already the Treaty of Waitangi, which is our contract with Indigenous people. And the government has been taking that very much more seriously in the last few years. Can I have the next slide, please? So I'm imagining that many of you will be familiar with what our Prime Minister looks like. She's become quite famous. She was famous early on, but even more so over COVID. And very early, she got up in front of the nation and she declared that we were going to be having what was called a hard lockdown. And for 5 weeks, as it turned out, the entire country were confined to their homes. We were allowed out to exercise in what were called bubbles, in our family bubbles, but we weren't allowed to have any physical association with anybody else. And she said here, everything that you'll give up for the next few weeks, it will literally save lives. And she went on to say, the worst case scenario is simply intolerable. It would represent the greatest loss of New Zealanders' lives in our country's history. I will not take that chance. The government will do all it can to protect you. None of us can do this alone. Can I have the next slide, please? And so what she led the way in really exemplary fashion was this coordinated effort of the whole of government. And the way that they were able to make that successful was through an extraordinary communication campaign. And in terms of the focus on health, you can see that in that first picture, that is our Prime Minister with the Director General of Health, Dr. Ashley Bloomfield, who is a public health physician. And the two of them presented every single day at 1 o'clock right through lockdown and have carried on doing that largely. And you can see in that picture that Prime Minister Ardern is deferring to Dr. Bloomfield there and asking for his opinion on whatever the issue is. And this was a very regular thing. And so it was very, very clear that this was a health-centred response all the way through. There was a public information campaign, which was about the whole country uniting together about how we were working together to mitigate the impacts of COVID-19. And then in our public health unit, the All Right team there developed a campaign called Getting Through Together. And they developed a whole lot of messaging, which was intended to support the collective and collaborative action that was needed. So that whole idea of the team of 5 million. And there was lots of positive messages about compassion, gratitude, kindness, hopefulness, this continued sense of community agency, that there were things that we could do, even if the thing that we were doing was actually nothing. The doing nothing was saving lives. And it was all about the greater good. So physical distancing, but real social solidarity. Can I have the next slide, please? So when I think about the health sector, the specific health sector response, there were things like increased ventilator capacity. A huge amount of time and money went into sourcing extra ventilators, which, as it turned out, we didn't really need any of them. All of the health workforce was categorised into risk levels, and anybody who was deemed to be too high risk was sent home. And all elective procedures were stopped in the health sector. Next slide. So the hospitals were pretty quiet. There wasn't an awful lot happening in the hospitals, but in the public health units, it was all hands to deck. We were deemed to be essential services and workers, and we were working really hard right through that lockdown on basic public health responses, contact tracing, looking after people who were sick or were deemed to be close contacts of a COVID case, and managing their quarantine in the home. So we had, these are just, public health basic things. We had the hard lockdown with various alert levels. The differing alert levels meant different levels of lockdown. We, like Sharon talked about in Australia, we had a wage subsidy, and that was an extended wage subsidy for businesses that was intended to keep people employed when the businesses weren't able to be open because of the lockdown. Essential services and workers were supported to continue, so basic things like supermarkets, food services. One initiative that was pretty impressive was that all homeless people in New Zealand were housed over the lockdown period. So the government paid motels to house anyone who needed it, and that has continued. So we have an initiative which many of you may have heard about that was first thought of in Canada, I believe, called Housing First. And it was found that when these homeless people were assessed, to many people's surprise, almost all of them were found to be eligible for Housing First support, which means that at a minimum you had to have been homeless for over a year. And so what has happened since the lockdown finished is that the government has continued its funding of those hotels so that everybody is housed in a motel, which is not ideal, but is better than being on the street, until March next year. And during that time, we're working to provide them with a more stable accommodation and whatever other support services they need to be able to access that. Another really interesting initiative was the provision of devices to all school children. Schools were mostly closed through that hard lockdown and then opened at various stages over the next few months. And so children needed to be taught online. And suddenly funding was found to provide everybody who needed it with a laptop and to support remote learning. So that wasn't a perfect rollout, it wasn't a perfect project by any means, but it did show that where there's a will, there's a way. And it also highlighted issues to do with not just device access, but access to the internet more generally. It's all very well to have a device, but if you can't access the internet, then you're not going to be able to use it in the way that it was needed. So a really interesting, flawed, but huge potential project. And then there was a national welfare hotline, so that people who had any particular needs around food, medication, anything like that, were able to call that hotline and get support. Next slide, please. So these are some of the social media tiles that the Getting Through Together campaign developed. And these were some of the statistics that were coming to light around about a month after our major lockdown ended. And this campaign was really trying to shape the public narrative around impacts, particularly on mental health. But we were wanting to support messaging around how we could be kind and to be proud of how we were helping each other, helping that whole team of 5 million to get through together. And also to show some of the positive findings from the lockdown, which had been a difficult experience for lots of people, but had actually had for many people brought many positive benefits, things like really good family times together, getting a lot more exercise, just generally getting enough rest and feeling a lot healthier in those ways. And so these tiles were meant to be helping people to focus on those kind of issues. Next slide, please. So in terms of the risk factors, just like I think Sharon has also spoken about, these risk factors are not unique to COVID. They apply to really any infectious disease and certainly any non-communicable disease that are so rampant in our country. And that also meant that the burden of the pandemic, the things that didn't go right, didn't fall equally across our society. And so things like overcrowded housing, inequitable access to education, poverty generally, these were things that are still problems and that need to be addressed as we go forward. And we found in our response that people who are on lowest incomes did the worst, people who were unemployed did poorly. People who were overcrowded were obviously at high risk for passing on infection once it was picked up. Next slide, please. So I just wanted to show you quickly, this is a slide from a British Medical Journal paper. This is the kind of thing that I had hoped that if we had a health and all policies approach in New Zealand that was really embedded and explicit, that we would have been able to use some of the tools of health and all policies. And this is something that a health impact assessment unit in the UK put together. I thought it was a great paper, a really great response. And it would have been nice if we'd been able to merge those things. So I think New Zealand did a lot better in action around managing the COVID epidemic than the UK has done. And maybe we would have done even better if we had had access to the kind of tools that were shown in this paper. Next slide. So looking at the benefits, the health impacts particularly, that we came out of the so far, the COVID experience with, a whole lot of what our government called shovel-ready infrastructure projects were developed, which were all about increasing employment. And we managed to get a lot of cycle lanes, a lot of bike lanes. So many, many kilometres of bike lanes will be built because of the COVID experience. We found the air quality improved dramatically. We found that influenza, which normally kills about 500 people a year in New Zealand, we have had no influenza in New Zealand this year. So that's obviously been a really big change. And we've had actually less suicides. Initially, there was some talk that we had more, but we've got the data now and it's very clear that we had less. And whether that's about people, this whole general process we had around supporting people, around that getting through together idea, maybe that had something to do with it. We're not quite sure yet. Next slide. So of course, it wasn't all perfect. We certainly found that alcohol and drug abuse has increased over the lockdown, and a lot of that has, in surveys, people have attributed to boredom. Shovel-ready infrastructure has not been checked for equity issues or wellbeing issues. Some families did really well over the lockdown, but for some families that were already at risk for domestic violence, for example, the lockdown wasn't helpful. And then there were initial delays in accessing some medical treatment, and cancer was a particular cause of concern. But already we're pretty much back on track with our cancer statistics at the moment in terms of in terms of diagnosis and assessment. Next slide. So locally, in my public health unit, we had already developed something called the Integrated Planning Guide, which I talked about a little bit earlier. And we very quickly worked with our partners, particularly the City Council and the Regional Council, to develop a pandemic supplement. And I put the links to both of those documents down the bottom of the slide there. We also worked really hard at maintaining relationships and working together on the joint work plans. We wanted to make sure that we kept going on our business as usual work, which we still saw as really, really important, while at the same time maintaining our COVID response. And we had a particular focus around disability advocacy, because we certainly recognise that at the best of times, people with disabilities are often inequitably served, and that was really highlighted in the COVID response. Some things were quite good. For example, those daily stand-ups that the Prime Minister and the Director General of Health did were always accompanied by a sign language translator. But in some ways, that's almost a bit of tokenism as well. So we did a lot of work around influencing decision makers to make positive changes for people with significant disabilities. And one of those things was that the Ministry of Health here in New Zealand developed a specific accessible information role, which was all about making sure that all people with different disabilities could get the information and the help that they needed. Next slide. So the things that we saw as enabling factors for collaboration in a crisis, which is, I guess, fundamental to health and all policies, was really strong leadership around that, and we certainly had that in the form of our Prime Minister and Director General of Health. Recognition and communication of shared goals, which we supported as a country, and the Getting Through Together campaign really enabled that to be strongly evidenced. And this idea that health contributes to the economy, it's not a dichotomy, it's not a binary response. Health is wealth. And I think more and more people are starting to understand that. Our response was very much science and evidence led, and communicated so well that we've really not had too many problems with disinformation. There is some, and we had a political party that rose out of nowhere, really around COVID disinformation. But in the elections, which were held just a couple of weeks ago, that party failed to get any traction at all. And at a local level, it was all about the pre-existing relationships that made the big difference for us. And at the bottom there, you can see a current project, a new project, where we're being asked to say, what do we want to happen in the future? This is a really big project that's led by all of the different councils in this region. And we are completely embedded in that project and have staff there working on it, have been contributing information to it and analysis. And that's something that's just happened in the last couple of months. So we feel that that's come about because of the pre-existing work. Next slide. So I guess the lessons that have been really important for us about the need to invest in relationships, especially with decision makers. And, you know, we have been doing that for many years now, and we're really glad that we have. And we feel like now we have a mandate to do that, even more of that. We need to show them the impact of collaborative action, and we've got lots of evidence around that now. And we need to continue the momentum at a national government level on addressing the big problems that Sharon also mentioned: child poverty, climate change, and equity. Unless we address those, we will fail to improve health and strength and resilience. And that is, to achieve those, we do need political will. And we need funding at levels that will allow change and innovation. And I guess what we've seen in our country's COVID experience is that that funding can happen, and it can happen very, very quickly where there's the political will to make it happen. Next slide. That's the end from me. I'm really happy to take any questions later on.
Thank you very much, Anna. I'm now going to hand over to our third and final speaker. Please, Warisa, will you show and share your PowerPoint slides with us? Thank you.
Okay. While waiting for the PowerPoint, I would like to thank the organizer for inviting me to join this event. And today I would like to share what are the roles of active citizens during the COVID-19 outbreak in the context of Thailand. Okay. So let's start with what had happened in Thailand. Thailand was the first country outside China to report a case of COVID-19 in mid-January. And most of cases in January and February were foreigner. And then later in March, there were two outbreaks. First was from the boxing stadium, and the second one was from the bar. So this led to the closure of many places, such as bars, schools, theaters. Also, mass gathering activities were canceled. Domestic and international traveling were limited. Cities were locked down. So, and you can see from the photos in the right-hand side that the Bangkok become very empty, which is quite unusual. Next slide, please. The COVID-19 spread rapidly and widely with a considerable number of patients at the community level. So to control the situation, the government decided to declare a state of emergency in late March. A curfew between 10 p.m. and 4 a.m. restrict all people from leaving their home nationwide. And in addition, during the peak of the outbreak, the other social measures were applied at the national level. Like in 17th of March, the government launched the Stay Home, Stop the Virus for Our Nation campaign, which was well received by all Thai. All citizens were asked to wear face masks, keep physical distancing of more than 2 meters, adhere to strict hand hygiene through washing and use of alcohol hand rub, be aware of touching their nose, the mouth, and all these social measures were recommended by health sector is to stop spreading of the disease. And technologies become supporting system to facilitate daily life activities. There are online meetings, online school, online shopping, which people can adapt themselves quickly. However, some have limitation in access to those technology, as they do not have mobile phone, no computer, or cannot access to internet, in particular those in the rural area. So this reflects the inequity in our society. And the IHPP, or International Health Policy Program, together with the National Statistical Office, jointly conduct an online survey to monitor citizens' adherence to the stay-at-home policy. So with the demographic data available, we can identify which group that we need to pay more attention in terms of the measures. And the findings were reported to the Emergency Report Centers, or EOC, for prompt actions. And later on, you can see from the photo on the lower hand side that there are more organizations joining this survey, including the Show, Mahidol University, National Health Security Office. So for now, we got nearly 1 million samples that we can monitor weekly. Next slide, please. And during the peak of the outbreak, we observed the power of active citizens in supporting others during their hard time. Pictures on the upper left are health personnel and even monks making face masks to give to those in need. And despite being a major food producing country, vulnerable populations face food shortage due to the loss of income. So they were supported by the voluntary food cabinet. As you can see, this is the cabinet full of food and other necessary essentials for the daily life. This was managed by individuals and community. The food cabinet was first introduced by civil society, then expand throughout the country. Upper right is a picture of free coupon that those in need can get free food that someone already paid for him or her. Another innovation is the famous Thai celebrities who established Talat Chai, or the central market. Talat Chai act as the middleman between those who would like to donate medical supplies or money or meals to health facilities. Each day, every day, there's a live stream inviting singers or actors for fundraising and provide mental support to health workers. Also, health workers can call to inform what they need. Sometimes it's even small thing like bubble milk tea or the ice cream that this is like mentally support to them. So this campaign can raise nearly 45 million baht, or around 1.5 million US dollars. However, this is not only about the money, but this is about the recognition of the huge contribution of frontline health workers and contributions of citizens to support others. Next slide, please. At the community level, the National Health Commission Office, or NHCO, work with the District Health Board to support community to develop community charters in response to COVID-19. This is the commitment of the whole community to stop the spreading of disease. For example, they commit that each has to wear masks in public place, or wash hands frequently, keep physical distancing, or do temperature check before entering public space. So these activities are financially supported by the community fund, which is the matching fund between local government and National Health Security Office, who manage public health scheme for 48 million populations. Next slide, please. And at national level, NHCO has organized annual National Health Assembly as policy-driven platform for all to debate on health-related agenda. And the theme this year is active citizens in response to health crisis, with 2 agenda on food security and crisis and participatory health crisis managed for pandemics. That has been a long process to get these 2 agenda, and NHCO organized many rounds of consultative meetings to get views from all stakeholders to consolidate the idea of what should be discussed at the assembly and develop the working documents. The first step is to get views and voices from all stakeholders, including academia, policymakers, private sectors, and civil society, to shape the resolution, which will be approved at the assembly in December this year. Next slide, please. So in conclusion, what are lessons we can share? The first one is the role of health sector during the pandemic should be able to reposition. You can see that at the beginning of the pandemic or the outbreak, health sector become dominate because we have to manage and control the disease. And but later on, then the health sector role is shift from the leader to facilitate when measures were relaxing. And the second one is that the citizen participation in the policy process make health and all policies responsive to the need of the needy. And the last one is that policy platform, including legal framework and the governance body, contribute to sustainability of health in all policies and multi-sectoral collaboration. And this is all the experience from Thailand. Thank you very much and ขอบคุณค่ะ
Nicole, you're on mute.
Sorry, I did push unmute. So ladies and gentlemen, you've seen 3 very clear and interesting examples from Australia, New Zealand, and Thailand. I would now like to address to read out the 2 questions that were submitted beforehand, and then address some questions to the panel related to these questions. The first question that we received beforehand was around whether racism in our society, which is insidious, would be addressed in our discussions. And the second question we received was, what are the best institutional arrangements for health in all policies that work at central government level, at the apex of government? So looking at those 2 questions and the topics covered by our presenters, the first discussion question I'm going to invite our presenters to address is the issue that was raised around in both, as in particular, I think all of the presentations, but in particular in Australia and New Zealand, was the priority of a health-focused response versus an economy-focused response. And my question is really, is it a health-focused versus an economy-focused, and an economy-focused, or is it health versus the economy for some, or the economy for the more disadvantaged? That behind that word economy, are we hiding something around the inequalities, whether they be racially structured, whether they be ethnically structured, whether they be socioeconomically structured in our societies? And shouldn't we, in the health sector, bring the debate there again? And I think that touches on the equity issue. But now I know it's a difficult question. It's one that I think all the governments around the world are struggling with, but I'd like to hear your views. I'll start off in the same sequence that we had the presentations. Over to you, Sharon.
Thanks, Nicole. Yes, I mean, a major question to grapple with. And I think, I mean, if you think of just the contrast between so my remarks from the Australian side and Anna's remarks from New Zealand, and I think really quite different in the sort of the embedding of principles and values of actual concern about society, which I think came across in New Zealand. And I would say we've not had that really in Australia. And that goes to your question, I think, of, was it health versus the economy, or health and or the economy for some? And when you saw in the Australian response, so whilst health has been right up there, of course it has, it was a COVID response, it had to be, the health goals were absolutely elevated, but it was really through let's protect the economy going forward. But when you peel that apart, and I think some of the analysis that we did really showed that it was about a response for some, and it was a response for the voter base that this government was trying to speak to. And that strikes, I mean, I think that's incredibly sad that the values driving a response, I also think the response and in the mechanism, and I'm speaking now really at the federal, the national level, the mechanism that has been put in place through the National Cabinet and the sort of the highest level committee to the COVID committee is chaired, well, that's chaired by the it's chaired by sort of values and principles that are not about equity or social equity or health. And so in thinking about how to move a health in all policy and health equity in all policy agenda going forward, getting the health and the social voice into that committee is absolutely vital, but has not been enabled. When I was listening to Anna, I was just so jealous of, how do you, and I want to know, what are the conditions, the factors that enable that level of political will to say, we care about everybody within our society and we're going to do something about that. So we'll pass on to others. Thank you.
Thank you, Sharon. Thank you very much. Now I'm moving over to Anna. And Anna, I wonder if you could also reflect on to what extent an integrated tool could be a mechanism to enhance this process. The tool you describe where you have the criteria of the determinants and you show the interactions between the determinants. I feel what I've heard said often is that it's not practical. It's the economy stupid. I forget which president was it, Reagan, who said that, of the US. But I feel that it's often put forward that it's not practical to focus on health. So I would like to I like the way you refer to local food production, local consumption, etc., which aligns also with the climate change agenda. So your reflections on health versus the economy, or the economy for some, or thanks, over to you.
Well, I don't think anybody's nailed this or got, the magic bullet of any kind. I think humans seem to be very, very poor at predicting the future. And so it felt like as at the beginning of the COVID pandemic, and as we envisaged going into a lockdown, and in the early days of the lockdown, there were many, many voices saying, we must protect the economy, we're going to ruin the economy, that will be the end of us all. And we were fortunate in New Zealand to have the Prime Minister who leads a Labour government, which is actually quite a central government, but it's perceived to be a little bit more progressive, a little bit more to the left of the political spectrum. And she really, that communication strategy that I talked about, she articulated a vision of what the future could be like. And I think the more she articulated that, the more she was able to create it. And as the whole country kind of got with the picture, so to speak, and we became the team that she spoke into being almost. It was an extraordinary communications exercise that was supported by both by the whole of government and by all political parties in New Zealand. And it was really also supported, of course, by the Director General of Health and those, frequent at least daily stand-ups, and the I think $20 million has been spent just on that communication campaign alone in the last 6 months. So I think that speaking of a vision that wasn't actually true yet, but the constant reinforcement of it did kind of make it become real in some senses. And then as things carried on, people started to see that actually the economy wasn't ruined, and that their fears had not come to pass. That's not to say that it was easy or that there weren't people who suffered economically. There absolutely were, but it wasn't as terrible as some people had predicted. And then as we came out of lockdown, and New Zealand has been in this incredibly fortunate position of being completely COVID free for almost 4 months. And then we had another outbreak. And I think that really, that second outbreak came along just as there were increasingly loud voices about we need to open up the borders, we need to get back into the world, the economy. And within minutes of that second outbreak happening, you could see all of that rhetoric just dissolving, as we once again realised that actually without our health, we have nothing. Without our community health, we have nothing to offer the world, that our economy will be in tatters if we can't control COVID. And now we're back in that position almost again, I think, where we have been largely community free of COVID in the community. And people are just now starting to once again to talk about the economy. But I think we are slowly, like humans do seem to learn very slowly sometimes, we are slowly learning that our economy is just a part of what we as humans, as communities, need to thrive. And we do need to protect our economy, but we need to make and build an economy that is fair and for all. And we've also just gone through, literally 2 weeks ago, an election. And so the country had to decide whether they're going to go with the current party, which was articulating the vision that I just talked about, or whether they're going to go with a much more right-wing party that was pretty much their whole policy platform was around the economy, jobs. And as it happened, it would appear that about 70% of our voting community decided that they didn't really trust that more right-wing version, and they were going to go for what they said over and over again, the person who kept us safe. So I don't know if I could talk for a long time, obviously, but I think that's probably enough.
Oh, thanks very much, Anna. It's very, very insightful. And as you mentioned, it is a very difficult question that we don't have the magic bullet for, but seeing the economy as just one aspect of what we need to thrive, and not, and that health does not necessarily prevent jobs. It doesn't prevent a whole lot of things, but rather is there to support a good economy. But without health, there's death and illness. So really the opposite end of the equation. Now I'd like to turn to Warisa as well. And Warisa, if you could give us your thoughts on this, and also perhaps lead us into a discussion related to the second question we had, which was around institutional arrangements. What institutional arrangements work well? I was particularly struck by your picture with the signs in the public transport requiring physical distancing, and reflecting on what kind of local partnerships existed in order to bring that into effect. So over to you, Warisa, thoughts on institutional arrangements, local partnerships, and also on the economy, which as well, and the health response. Thank you.
Okay. I I try to respond to all the questions. In my view, at the during the peak of the outbreak, of course, that would be health focused measures that how we can contain the spreading of the disease quickly, and we have to keep our guard high. So all the measures are about the social distancing, how you have to stay at your home. It's not at that time. It's not economic focus. It's only the health focus, and people try to adapt themselves quite well. So when the measures become relaxing, the restaurants try to adapt themselves how they can open. We still can keep those measures. The Department of Health, Ministry of Health, has launched the guideline for all theผู้ประกอบการ the entrepreneurs, how they, if they would like to open or reopen their business, what they have to do, what are the things that they have to do. From the photos that I already show, that you can see that in the restaurant there's a screen between two people. That's how they adapt themselves at the local level. Or even the food cabinet is totally from the people at the local level. So once when the outbreak becomes subside, this become the national policy seems to be the focus more on how to boost the economy. And we try to encourage people to travel around the country. Even there's no international traveler in the country, but even Thai people, we encourage them. The shop start open, but still they still have to keep all those health measures. Everyone has to wear the mask. We need to have the temperature check before entering to the shop, or they need to provide a alcohol gel at the entrance, for example. So this is how we adapt them ourselves during the pandemic.
Thank you very much, Warisa. I'm now going to move into, I suppose, it could be a closing set of remarks, and I'm going to put forward two questions, leading on from the question I asked Warisa, and that was addressed to the speakers. What kind of institutional arrangements do you think are very important for the health sector to have and to develop better in terms of for multi-sectoral collaboration going forward? I think we've spoken a lot about the need to have the new vision. And so a comment on perhaps the relationship between the health sector and the central government, also between the health sector and local partnerships would be appreciated. Another reflection I would like is if the three countries we've been talking about, I think, have been among the lower in terms of the impact of the pandemic. And I can imagine that in our audience, we have people from different settings with different high burden or high impacts of the epidemic in different stages. And they're all seeking to look at how to understand and or advance health in all policies in their different contexts. So if you put yourselves in the shoe of a high burden environment, and you have the pressures on the health sector, both to respond immediately, but also to be using the opportunity to build a better health security, a better economy that can be more health secure. What would your advice be, really, if you have to put yourself in their shoes, maybe thinking back to the time when there was more a higher rate of the epidemic in your respective countries? So those are two sort of points of reflection, one on the institutional arrangements that have been important and that are important going forward. And secondly, in that, perhaps using the institutional arrangement example to reflect on if you're in a high burden country and you have to look at the role of the health sector, how do you take that forward, those relationships, those local partnerships, building the work with the central government to create a different vision of health and the economy. So let's take it as the closing remarks. I'll start off just to vary things a bit. Maybe if I start off with Anna and then go to Warisa and then we'll close with Sharon. Thank you very much.
I don't think that we need to do anything particularly different than what we have often talked about before in the health and all policies community. The same, the issues of ensuring that we are credible voices, that we can build trust between the people, the different agencies and groups that we're trying to talk with and to. The idea of trying to leverage projects to work in a win-win way with our partners, I think those remain just as relevant as they ever have been. Maybe this COVID pandemic gives us another opportunity, and there have been pandemics before, H1N1, Ebola. There are other similar times like this, but this is perhaps the first truly global pandemic in many people's living memories. Perhaps this does give us another platform to speak of the same issues, but with a COVID lens. And perhaps it provides us with a new evidence base that shows the value of a collaborative approach to problem solving. One thing that I think is quite important, and I don't know quite how we change the rhetoric around this, but when I think about countries like particularly the USA, which has a very individualistic approach to its healthcare and to its whole of society, and if you contrast, and the USA is clearly a high burden, I think that was the phrase that you used, Nicole, has a high burden of COVID, and when you contrast that with what is often an Indigenous people's perspective, which is much more about the whole group, the whole community, far less individualistic. When you are working for the community, then the approaches that you take are different often than the approaches that you might take if you're just working for the individual, if you're just working for yourself or for your own nuclear family. And in a pandemic situation, and many other situations, but that's the one we're dealing with now, in a pandemic situation, it turns out that when you work for the good of all, then you are also working for the good of the individual. And that is something that I think in New Zealand, our Prime Minister, as I've already spoken about, was able to articulate really clearly that we wanted to do this together, that we were a team, that we were looking out for each other, that the sacrifices we were making were particularly for vulnerable people, but ultimately for all of us, that the interventions that were being made were to alleviate the pain for those who were most affected, but that was for the good of all of us. And I think that has, along with many other things, New Zealand is an island, so that's been very helpful for us. But that was a really important way, a really important approach that she led from the top from. So I think that would be that's my closing remark. I think that would be it, is how do we foster a more community focus as opposed to an individualistic focus, and think very carefully about the means that we use to achieve the good result for everybody.
Thank you, Anna. Warisa, over to you.
Right. In terms of institutional arrangement, In Thailand, we have set up the Center for COVID-19 Situation Administration, which led by the Prime Minister. And these are all the committee that include all the ministers together to tackle with the COVID-19 outbreak. We also have the Center for Economic Situation Administration. As I mentioned earlier, that now we try to put more focus on how to boost the economy. At provincial level, we have Emergency Operation Center with the provincial governor chair this center. So these are the example that how we put everyone in the same platform. However, these are all the government oriented. These are all the governmental side. So recently, the agenda for the National Health Assembly this year is also about how we deal with the emerging infectious disease. The draft resolution has the recommendation that how to make all this center more permanent, as this seems to be the ad hoc one. The second point is how we can get more multi-sectoral involvement, in particular the civil society and the private sector. As we can see that during the peak of the pandemic, we cannot depend on the public health facilities. The private one had the big role at the beginning of the outbreak as well. So this is my response to the first question. In terms of the second question about the high burden country, what are the role of the health sectors? I think for the health sectors, the resilience of the health system is quite important. In particular, in terms of COVID-19 services. And the second one is the non-COVID-19 one. How to maintain the essential health services during the crisis is very critical. In Thailand, as we already achieved USC nearly 20 years ago, we have the good foundation of the health system that well distributed across the country, as well as the adequate funding or the financial support from the government. So this is the key factors that we can maintain our health system during the crisis and can contain the spreading of the disease quite quickly. So this is all my response to these two questions.
Thanks. Thank you, Warisa. And now over to you, Sharon.
Thanks, Nicole. Well, I think, so we have a very important moment right now with COVID, where health has been elevated into the political and the public psyche in a way that has never happened before. And so health has all sorts of authority and legitimacy now within politics, policy, and the sort of the wider public. And so I would say health should be chairing the national cabinets. Health should be in all of those economic discussions. But I am serious in terms of health should be the chair of those, you asked about the sort of the central level mechanisms, because very quickly health will become subservient, I think, to the economic argument again. But right now there is that elevation. And we've also seen that the policy silos, both the physical and the mental silos that are so entrenched in many places, they've been broken down. And I think some analysis as to what actually happened there would be very helpful for health and all policies, certainly going forward. And of course, many colleagues who work centrally within the health, who work very much within health and all policies, you'll see that so easily as to like what changed in that process. So seizing the moment of authority and legitimacy with health, the silos that have been broken down physically and mentally. And then the third thing is we cannot let people forget that before COVID, we had, and we will see even more of this in terms of this tsunami of non-communicable diseases, of inequality that was always there and that will be there going forward. My final remark would be, in particularly for countries who have that very high burden and where the language of securitization is very prevalent, and that I have to admit worries me, because when we move towards a securitization language, we have a very particular paradigm being set in motion there. And we also have a set of actors who are not the public health or the social model of health, if you like, that many in the health and all policies. So I think being cognizant and being careful of a health security, a complete securitization lens would be something. And I think that's therefore the role for the health sector, the public health sector, the health and all policies community to be very vocal around ensuring the paradigm that moves forward is a social model of health.
Thank you very much. We've just finished our time. I want to thank all the people who joined us in the audience. It's been lovely having you. I want to thank very much the speakers for their excellent presentations and wonderful reflections. It certainly encouraged me going forward. I think COVID has been an opportunity, a wake-up call, and it provides a way for us to envisage and have a vision of a more caring world, a world that is more sustainable, economies that are sustainable, communities that are sustainable and fairer. So we look forward to having another webinar in a few weeks' time on the same topic. It'll be oriented towards other time zones, I should say. But thank you for those who joined us here. And please, if you want to join us at the next one, you're also welcome. This is an initiative of the Global Network for Health in All Policies. And the network is really committed from the practitioners who are working in different countries around the world to furthering health in all policies in different settings, from community all the way up to national. If you want to know more about the network, please link back to the website, and the Secretariat there can give you more information. So thank you again for our wonderful guests. I give you my applause, and I thank everyone who participated. So goodbye, everyone, and have a good evening, afternoon, morning, etc.
Thank you. Bye-bye.
All the best. Thank you.